Cardiovascular examination include vital signs like blood pressure, pulse, radial pulse for rate, rhythm, and volume. And pulmonary examination may also be included in some part of it. And assessment of leg carotid vasculature for vascular disease. So there are three basic components: inspection, palpation, and auscultation. Percussion is usually omitted in the cardiac examination because the accuracy of this method in cardiovascular or precordium examination is not that pertinent. Patient should be professionally touched with a reasonable exposure with preservation of modesty and palpating sensitive areas for the sake of accurate examination. The key for effective examination is to explain what you are going to do. Be artful with gown and drapes. Getting on a female assistant to help with exposing female patient only areas of examination. Do not rush, don't be careless, be considerate of the patient. Chest shape, ability to speak, shortness of breath, visible impulses through inspection or observation is of paramount importance. While doing inspection of the precordium, as you can see in this figure, the surface anatomy of the heart and the relation of the chambers to the surface of the precordium, and you can see that right ventricle is lying anteriorly whereas left ventricle is lying posteriorly. Sternal manubrial angle, aka angle of Louis, is a key to identifying the valve areas because it is at the location nearest to the second intercostal space. As shown in the figure, the sternum and manubrium intersect at the angle. The areas of valve are not exactly the same as the auscultation areas, and they roughly correlate with auscultation areas. For example, mitral valve would not be exactly at the mitral position of auscultation, but it may be roughly near that space. So while palpating right ventricular heave flat with the heel of the hand, prominence described as a lift or heave, thrills or vibrations with stenotic murmur usually felt like king garden hose. Spread your fingers on the chest like in the picture to feel the apex. Gradually locate to one or two fingertips. You can tilt the patient to left side to palpate if impalpable. Feel for vigor, feel for thrill, feel for size and location. For right ventricle, vigor of contractility is felt with heel of the right hand across the left of the sternum. As right ventricle is an anterior structure, you can put the heel of your right hand on it and feel for the RV heave. Any stethoscope is good, with the one with thickest tube and diaphragm for higher pitch, while bell for lower pitch sounds. Always have a steth with these two things clearly maneuverable. Heart is unique organ. You will still have finding in normal people with S1 from mitral tricuspid valve closure and S2 from pulmonic aortic valve closure, as shown in this cardiac cycle, systole and diastole. Systole is time between S1 and S2 and diastole is time between S2 and S1. So it is dynamic process. Physiological splitting is aortic and pulmonic splitting, audible with inspiration. You can see in the picture. Patient should be at 30 to 45 degree with chest exposed, male or loosely fitted gown in female. Need to see area where placing stethoscope. Stethoscope must contact skin. Stet with diaphragm. Higher pitch sounds engaged. First, do not snake the stethoscope down the shirts. These are the wrong techniques as shown in the figure. Over the cloth, over the gown, over the bra. Do not auscultate through clothing, and do not snake your stethoscope down shirts or gowns. Auscultating female patient you will require a female assistant to touch the patient with the stethoscope at proper areas, and you guide them, or you do it yourself if there is no female attendant in presence. This is the good option as shown in the figure. Keep the modesty of the patient in as a prime importance. Start over aortic area, second right intercostal space, use angle of Louis as landmark, then to pulmonic area, second left intercostal space, inching down to tricuspid at fourth left intercostal space, and then towards the mitral area at fourth intercostal space, mid-clavicular line. Precise location doesn't matter, gives you a sense of change in sound as change location. Inch the murmur if you hear anyone and follow it to the area where it is heard the loudest. In each area, ask yourself, do I hear S1, do I hear S2? S1 is louder or S2 is louder? What are relative intensities? Interval between S1 and S2 is shorter than between S2 and S1. Can also determine timing by feeling pulse, a systolic event. Listen for physiological splitting of second heart sound. Murmurs are sound created by turbulent flow across valves due to regurgitation or stenosis. Systolic murmurs, aortic stenosis, mitral regurgitation, pulmonic stenosis, tricuspid regurgitation. Diastolic murmurs, aortic regurgitation, mitral stenosis, pulmonary regurgitation, and tricuspid stenosis are diastolic murmurs. Diastolic murmurs are usually not so harsh sounding as systolic murmurs. Leakage occurs when the valve closes and obstruction when the flow approaches the valve and it is stenosis. Murmurs are characterized by position, cycle, quality, intensity, location, and radiation. Barely audible 1, readily audible 2, louder 3, louder with trill 4, louder audible without a stethoscope, and intensity doesn't correlate with severity. Extra hard sound like S3 and S4. S3 follows S2. Blood from LA colliding with blood in LV occur with heart failure. S4 precedes S1 caused by atrial systole against a non-compliant LV hypertrophy from hypertension. S3, S4 are soft, low pitch, heard with bell, especially in the left lateral position. Abnormal beyond 30, when both are present, are referred to as gallop sounds. Can be heard over the RV. When auscultating, ask yourself, do I hear S1, do I hear S2? Listen in all major areas. Try to hear physiological splitting of S2. Try to hear before S1 and after S2 for S3. Characterize the murmur, systolic, diastolic with its intensity, character, duration, and radiation. In carotid palpation, each side for rhythm and character. Radiation and stenosis auscultation is done for the carotid bruit in carotid arteries with the bell of the stethoscope. Carotid bruit is auscultated. In tangential lighting, look for JVP and its wave, ACV waves, and X and Y descent. Try to differentiate from the carotid pulsation and respiration. Hepatojugular reflux for any rise in JVP with pressure on the right hypochondrium. JVP is 5 cm. Height sternum-mandibular angle is above RA plus vertical distance from sternum-mandibular angle to top of pulse wave. Normal is less than 8 cm as shown in the figure with 2 scales. Examine the femoral area with inspection first and then palpation from lateral to medial. Do not skip femoral observation. It is extremely important. You may palpate lymph nodes as well in this area. Keep the modesty of the patient as of prime importance. You can also listen for any bruise, vascular disease, or fistula here due to previous coronary angiography procedures done through the femoral artery. Popliteal pulse is felt behind the knee with slightly bent and fingers pushed into popliteal fossa, assessing for the popliteal artery, also examining internal structures, any palpable mass or anything else there. Vascular examination of the lower limb is important for assessing any venous or arterial or lymphatic problem that may lead to swelling of the legs. Generalized causes will lead to bilateral leg swelling. There are three types of problems shown: peripheral arterial disease, venous disease, and also a unilateral lymphedema in the lower part of the picture. As you can see, arterial disease will lead to predominantly shrinking, while venous insufficiency swelling. Swelling, discoloration, ulcers. Also looking at bottom of the feet and between toes, and for the symmetry between the legs, as atherosclerosis and neuropathy, especially in diabetics, can lead to this problem along with other vascular issues. Temperature with back of hand for inflammation or coolness due to atherosclerosis or hypoperfusion, and also capillary refill, color returning in less than 2 to 3 seconds after pressing the nail bed, and release. Systemic problems like heart failure, renal, liver diseases, and venous stasis can lead to leg edema and unilateral due to DVT infection, cellulitis, trauma, or lymphatic obstruction. There might be unilateral leg edema if these are the causes. Edema can be 1 plus trace or 4 plus a lot, with depth in pit after pressure on the lower part of the ankle in the palpable bony part. The depth of the edema may be assessed as well. Dorsalis pedis is just lateral to extensor tendon of great toe, and 2 to 3 fingers may be used to push gently and feel it. It is 0 not detectable and 2 plus normal. If unsure, 10% patients may not have a dorsalis pedis. Posterior tibial is localized posterior to medial malleolus, felt with 2 to 3 fingers, and same rating scale as dorsalis pedis. Start on top of malleolus and work toward the Achilles tendon while feeling for posterior tibialis. Posterior tibial artery, to be more precise. This is the summary of skills. Thank you very much.